previous video, we talked about the basics of audiograms, and today we will build on it. In case you haven't watched it, here's a quick recap.
Ready, go!
An audiogram shows the result of a hearing test built on audiometry using an audiometer, which can connect to headphones, insert phones, or a band conductor. By wearing those, patients can hear the beeps presented to their ears and press a button to notify the audiologist whether they can hear it or not. The audiologist then maps out the patient's hearing thresholds in dBHL on an audiogram. The horizontal axis shows the frequencies. The higher the frequency, the sharper it is.
Like this?
The lower the frequency, the duller it is.
Like this.
The vertical axis shows the loudness of the presented tones. Here's what a normal hearing result looks like. The red circles indicate the right ear, the blue crosses indicate the left ear. All these thresholds are within 20 dB, which is the normal range. Today's video is designed for health professionals. We will see how a complicated audiogram is obtained by an audiologist, so we can understand it very well, and touch on the important audiology concept, masking, as well as how it affects the audiogram. Let's welcome our patient volunteer today.
Hi, my name is Helpful. I have a very inquisitive personality and I have trouble hearing. So I need a hearing test.
Thank you, Mr. Helpful. Let's get started. Please take a seat. I'll put the headphones on. You listen to the beeps, and here's the responder. You know what to do. So we have got the air conduction thresholds for both ears. This is obviously concerning due to two main things. Firstly, both ears are outside the normal hearing range. And secondly, the hearing loss is asymmetrical. The left is a lot worse than the right. But we haven't completed the audiogram, so we need to understand what kind of hearing loss it is. It could be either a conductive hearing loss or a sensory neuron hearing loss. A conductive hearing loss is caused by the issues in the middle ear or the outer ear. A sensory neuron hearing loss is caused by problems in the inner ear, the cochlea or the hearing nerve. In order to find out the type of the hearing loss, we need to put on the bone conductor.
OMG, I did not expect that.
Alright, this one sits behind your ear. It is testing your underlying hearing. It bypasses your middle ear and presents sounds directly to your cochlea.
Okay.
This is what we get from the bone conductor.
Blue is left, red is right, so my underlying hearing is about the same for each ear. They seem normal.
Well, no, we cannot say that so far.
Why?
Because the bone conductor can produce sound waves that go through your whole head.
So it's like electricity which travels through my whole body to create an electric shock.
More or less. Although the bone conductor was placed close to one cochlea, the other cochlea can still hear or feel the tones too, with little or no attenuation.
I see. You are saying my head is not very soundproof.
Yes. In order to stop the non-tested cochlea from hearing the tones presented to the tested cochlea, we need to put some masking noises into the non-tested ear. The noise will mask out the tones arriving at the non-tested cochlea, so it is called masking.
Is it possible for the noise to mask out the desired tones in the tested ear too?
Yes, we call it overmasking. That's why you need an audiologist to do all the calculations to avoid that situation.
Can you explain how?
No. Okay, just wear the insert earphones for me. Now you will hear some noises coming into your right ear and some tones coming from the bone conductor behind your left ear. Just ignore the noises, but press the button for the tones you'll hear. In this way, the noise will stop the non-tested ear from hearing and responding to the tone. Therefore, we can be sure that every response we get is from the cochlea that we intend to test. This is what we get. The square bracket symbols indicated the masked bone conductor thresholds or BC thresholds.
I see. My left ear is down.
Yes. There is a sensory neural hearing loss in your left ear. The square brackets plus down arrow symbols at 3000 and 4000 Hz indicate that no response was obtained at the audiometer limits. which suggests that your hearing at these frequencies can only be worse than 60 dBHL.
I see. How about my right ear? Do you need to mask the right bone conductor thresholds too?
No, we found out the true BC thresholds of your left ear, so we can deduct that the unmasked BC thresholds we obtained earlier must be the response from your right ear.
Okay. Are we done then?
No, we need to mask the left AC or air conduction thresholds. There is a big gap between the left AC and the right BC. Potentially, if we play loud tones into the worse ear, the better ear will pick it up. The left ear is the worst ear in this case. The loud tones coming into the left ear will be heard by the right ear, since it is so loud, even though the left cochlea may not be able to hear the tone. So again, we'll need to mask the better ear and hopefully can obtain the true hearing of the worse ear.
So it is basically the same reason as for BC masking.
Exactly. Alright, let's put on some earphones. Noise will play into your right ear and tones to your left ear. Again, ignore the noise, respond to tones. And this is what we get. The filled crosses are the masked AC symbols. These show the true hearing of your left ear.
Both. It looks horrible.
It is. Finally, we have completed the audiogram. To conclude, there is a mild mid to high frequency conductive hearing loss in the right ear.
Hang on. How can you tell?
What we are looking at is the differences between the true AC thresholds and the BC thresholds. If there's no gap in between, or the gap of less than 15 dB, like this one here, then there's no conductive hearing loss. But if there's a gap of 15 dB or more in between, like here, we say that there's a conductive hearing loss. So that's how we come to that conclusion.
Okay.
The left ear has a mild to profound sloping sensorineural hearing loss. No conductive hearing loss components since the airborne gap is less than 15 dB for all frequencies tested. However, this conclusion is purely based on the audiogram. In real life, we need to incorporate the results of tympanometry, speech perception testing, and history to get a good overview of an individual's hearing. Especially in this case, the conductive hearing loss in the right ear is very subtle. We definitely need to look at a tympanometry result, or even OAEs, to understand whether it is a real conductive hearing loss or not. In terms of management, the patient will be referred to a GP, who is likely to refer the patient to an ENT, ear, nose and throat specialist, to investigate further. For the conductive hearing loss in the right ear, sensorineural hearing loss in the left ear, and the asymmetry which could suggest more complicated pathology. If the onset of the left ear's hearing loss is sudden, i.e. within 3 months, immediate action is required. Research has shown that sudden hearing loss can sometimes be reversed by taking steroids. The sooner, the better. In other situations, we will refer the patient to hearing rehabilitation services. Given a hearing loss like this, he is likely to have difficulties with hearing speech in noise, sound localization, hearing soft speech, and clarity of speech. It is worth having a consultation with an audiologist to specifically discuss possible remediations. That's it for today's video. We talked about masking, reading a complicated audiogram, audiogram interpretation, and patient's management. Please comment below to let me know what else would you like to know more about. Again, thank you for supporting my friends. I'll see you whenever I see you.